Okay, so today we're going to be talking about penetrating trauma. I'm going to go over this lecture fairly quickly. I'm going to hit the highlighted points as we're dealing with trauma. So as we go through this will be a good chance for an overview for you. When we're looking at this, we're looking for the pathophysiology of exactly what happens with penetrating trauma versus blunt trauma, which we'll also be doing that lecture as well. So as we talk about this, we're going to talk about the type of injuries that are going to come from that penetrating trauma, um, deaths that are going to be coming, and how that's going to affect how you guys treat this. So really the principles that we're going to be doing this is talking about that energy transfer that comes through with penetrating trauma and the different aspects between high velocity, medium velocity weapons, and low velocity weapons, and what's going to come from there and how those different injuries are going to present. I'll go through some videos as well with that. But the kinematics of this, again, that we're talking through is when that object comes in with a certain amount of energy, it's going to transfer that energy over to this area that it hits. And that mass to energy relationship is what we're going to talk about of where velocity comes through. The faster it goes through and penetrates, it also brings this wave that's going to cause injuries to it as well. Different bullets are going to travel at different velocities. It's going to cause different damages based on how it moves and how it transfers that energy. I'm not going to hold you guys responsible for the laws that comes through, but basically the big thing is we're talking about mass by times acceleration. Acceleration is going to be the big difference over mass. The faster it goes, no matter the size, is how it's going to cause the path. When we talk about ballistics, we're talking about the pattern of how that bullet is traveling, whether it spins, whether it rotates. And once it hits, it causes basically what's called a cavitation. It's going to have that hole coming through, but we're going to have that wave, the pressure's coming through. With the high velocity, it's going to have this large wave or cavitation injury through where the lower velocity would be less. The caliber of the bullet, how it hits is also going to be the difference, whether we're talking like 22 and very small or we're talking a very large. Um, Also, we're talking about the stability of it. So, in flight, is it doing a straight flight and it's moving fast, or is there a yaw to it and it changes? Is it designed to expand? We talk about, and I'm going to show you a picture here in a minute, of the bullets that come through, and they're designed to expand on some of these when it hits, so it takes more surface area, causing more damage. Some are designed to hit and actually spin and rotate through, or velocity off. Other ones are designed to fragment. So as soon as that bullet hits and it strikes, especially from the rifle, it's going to fragment out into several pieces and shoot throughout the entire body, causing more injury. So there are different type of weapons, and based on that is we're going to try and spec the type of weapons there. But that energy transfer is the big thing. We've talked about, especially in the military area, having body armor, having things to help stop that impact or absorb that energy. When we're dealing with smaller weapons like a handgun, short barrel, these are going to be low to medium velocity, depending on the type of there, they can cause direct injury. Here's kind of a cam with a low velocity weapon. When it comes through, its shock wave is minimal, but it does open that area up. Now we're dealing with a high velocity, like a hunting rifle or that. When that bullet comes through, the bullet is going to actually put a small hole into the area, but because of the velocity and that speed that's coming through, it's going to have a shock wave or an energy wave that's going to go through. And I will show this to you guys with some ballistics gels shooting, but now that same bullet with a high speed goes through the can, that shock wave, the actual hole, the entrance and exit is a small hole from that portion, but the shock wave is what takes it out. So these assault rifles, larger hunting rifles, that it's they can shoot bigger rounds, but it's that energy transfer so much bigger, and that shock wave comes through, causes so much more damage. An alternative, we have a shotgun. We always talk about the shotgun approach. Basically what happens there is we're shooting multiple projectiles that come out. These slow down over a period of time because they are projectiles. So from a further different shotgun blast, it's going to slow down and you may get pellets and get initial skin penetration. At close range, it's going to be one entrance, looks like a bullet, but now those are going to spread out and come out the back. So the distance there is going to be the big difference with that, because that, again, acceleration is going to slow down over a period of time. Other type of weapons that we're going to see out there, there's hunting tips for arrows that are designed to spin and capture. There can be low penetrating depending on the length, and again, that acceleration is going to be the difference. and the type of injuries we're going to see. We're going to see initially that direct injury, and that's where the bullet arrow is going to come through. But the secondary injury we're going to see is that pressure wave, and the pressure wave is what's going to cause most of those injuries coming through. Here's an example of that, so you can see where the temporary cavity comes in. This is going to be just from that direct injury, the bullet coming in until it stops, but that cavity or that wave is going to be the big difference. So we have our permanent cavity where the bullet comes through, then we have our zone of injury that's going to extend over there before that wave comes through. Other factors we have that is there's going to be heat injury, how close it is. The entrance wound's going to come through, and you'll have how far it goes. Was there something to stop it in the way? What other factors are going to be able to help dissipate that area? Other organs that are going to be injured, obviously we got our heart or brain, are critical ones. We've got large vessels that can go and cause great damage. We've got solid organs, which if we tear them, especially in the liver, kidney is going to cause extreme damage on there. And then we also have our hollow organs as well, which we're going to see in the abdomen, especially with our intestine, our spleen, and others too. So we can have, again, our heart going through and get a pericardial tamponade if we just breach the heart and we get leakage in there. We can also leakage of bowel contents in there, and that's going to get us a septic patients. Anything to the lungs that penetrate there, especially with projectiles, we're looking for tension pneumo, hemopneumothorax, all those. And then we're looking at bone. Again, a lot of times we can get areas that hit the bone, fragment the bone, and bounce off. We can get areas that the directory changes. As far as the skin covering that, we're going to get other injuries coming through, and I'll discuss that another time. And then the abdomen I talked about all through there is those belly bleeds is going to be the big thing that we're looking at. Liver is the big aspect. Spleen, not as worried about. Kidney injuries as well. And if that abdomen, though, does get perforated in there, we're looking for those septic patients, and that's the big thing. If we get hit in the chest, obviously our big thing, our heart is our major area, our lungs is secondary. And then we're going to be looking for the aorta and other aspects of that vena cava and where the injury is there. When we're dealing with the neck, obviously blood vessels are going to be a huge area, as well as our airway. Airway is always concern. Is this something that went through there? We've got compromise. We need to get a tube. We need to go in and directly take care of that. Head injury, obviously we're going to look in from the skull and where it comes from the brain. We're always scared when we get low velocity weapons like 22s because they can enter the skull and bounce around inside there, and there is no exit wound. So with all these, we're always looking for entrance and exit wounds, especially through eye areas, orifices, other things like that it could exit to. When we're dealing with suicide attempts, obviously as well, we're looking for that entrance, and usually the big thing we see is a 22, where we see one entrance wound, no exit wound. Those are going to be our concerns. Here's our major organs right down the center position-wise. And again, I want you guys to be very familiar. So if I say we see an entrance wound in this area, what organs are going to be affected? And then based on the bullet profile, high velocity, the weapon shooting, all those, what are we dealing with? Are we dealing with a close range versus a long range? Because if we're dealing with close range, we're also going to see some marking or entrance wounds, some area coming out to that where we see the gunshot and blast around there too. You can actually see some burning on skin when we're at point blank range. So we will get burns that are associated with that. Biggest thing we're looking for is the physical damage coming, again, as the bullet goes through, straight shot through and through if we're finding entrance and exit wounds. Here's an example of one of those. But we're also looking, based on the velocity of weapon, if we can find that, of how much other injuries we're going to see. It's the same thing when we see a knife type wound. When we see a knife wound, we're looking for what's the depth that it went in, what's the focus of turning in basically a conical shape so we can see how much damage. Anytime we're dealing with a stabbing, shooting of that, obviously we're going to be taking care of ourselves first, making sure the scene is safe. That's going to be the biggest priority. Making sure that law enforcement is on scene. But as we're coming into those areas, we need to check very carefully when we're moving patients, looking for shells, looking for any other weapons that may be on there. We're also keeping that for protection of custody with evidence and control of that. So once we get this, the big thing is trying to determine what was the aspect that caused the penetrating injury. Is it a knife? Is it a gun? If it is a knife, how much of the knife was put into there so we can get that conical shape and understand if it was a gun. Are we dealing low velocity, high velocity? Are we handgun? Are we assault rifle? How many entrance wounds do we have? How many exit wounds do we have? And try to calculate for each of those. Once we get that, then we need to go, what was the path of the bullet from the entrance to the exit wound? Usually our exit wound is going to be bigger than our entrance wound. And then figure out what is our potential injuries, what do we suspect, what's our diagnosis from where that path went. Same as when we're dealing with a knife. When that area goes in, what's the conical shape? If it was done right in the abdomen area, could that affect multiple things? When we're dealing with facial trauma, our big thing is always going to be airway. When you get a patient like this, it's not going to be too easy to intubate that patient. So a lot of times we have to do a crike. That's going to be something that we'll talk about and go over, and you guys have to be very proficient in that, because especially in suicide attempts, we don't have anything, or sometimes we're pushing a tube in and looking for bubbles. Anytime we're dealing with chest wounds, obviously sucking chest wounds, I do have a video I'll show you guys on that, but we need to cover that with occlusive dressing. Otherwise, we are going to develop a tension pneumothorax with that as well. So we get that covered in 3 sides. Any other penetrating, we're going to, based on the depth, length, wherever there, we're going to be looking for heart. And so we want to make sure that we're getting a 3 lead and a 12 lead on this. We're listening to pulse pressures, see if we're getting any of those pulse pressures increasing. As far as wound care with any of these, anything that is still in place, knife or that, we're going to stabilize in place. We're never going to pull anything out, any impaled objects, because we can actually cause more damage with that. They may actually be holding tamponade against certain vessels, and you release that, pull that out, and we're going to get excessive bleeding there that's uncontrolled that they can do in surgery. So any of those we have to be very careful. Those associated with gunshots, though, again, obviously going to be higher critical. We're looking for doing an activation immediately and getting that patient in, because what they're going to need is they're going to need surgical care. And that's going to be the big thing. So I want you guys to be able to get a differential diagnosis of